نعم نعم.
ها؟
شوف السلايد واضح جدا.
بسم الله توكلنا. بسم الله الرحمن الرحيم. Today we will talk about introduction to rheumatology that will include rheumatology terminology, classification, common diseases, and signs and symptoms, laboratory investigations, and also will speak briefly about hands examination. So, this is your first lecture in rheumatology, صح ولا؟
نعم يا دكتور، هذه أول
نعم دكتور.
You have never ever seen any rheumatology lecture, صح?
Yes.
the first time.
So, anybody of you can tell me what is rheumatology? What is the meaning of rheumatology term?
أمراض المفاصل.
In English.
Inflammation of the joint.
Rheumatology does not mean inflammation itself, but it means a medical science dealing with disease and abnormalities in musculoskeletal system, and also includes connective tissue. Okay? So we'll speak about rheumatoid arthritis, which is one of the most common diseases, seronegative arthropathy, including ankylosing spondylitis, psoriatic arthritis, writers, and enteropathic arthritis. You all know about systemic lupus erythematosus, scleroderma, and polymyositis and dermatomyositis, vasculitis, Sjogren's, and juvenile idiopathic arthritis, crystal-induced arthritis, pseudogout, degenerative diseases, and bone diseases like osteoporosis. So rheumatology does include all of these, among others, but these are the most common diseases you will face in rheumatology. So as introduction, you need only to know briefly about them, and you need to know the most common features of rheumatological illnesses. So what is this?
Joint capsule and joint structure.
Yeah, this is joint. Any joint does contain two bone articulating together, covered by synovium, which is very with the blue color here, the thin red color here, which is very important. Why it is very important?
It has a fluid inside the synovium.
The synovium itself, it does cover the joint, and it is the primary site where inflammation in rheumatoid arthritis does happen. And it is covered with joint capsule, and all of them are covered with joint ligament. Inside the joint, you will find synovial fluid and the cavity, and you might see the cartilage, which articulating both joints, both bones, besides some menisci, as you can see here. So you have synovium, synovial fluid, articular cartilage, ligaments, joint capsule, and tendons, bursae, and muscles, fascia, bones, and nerves, and underlying skin. The bursa does what is the role of bursa here?
The bursa,
Hmm?
the friction of muscle on the bone.
Okay, yes. So you can see it here underneath the tendon. It covers the tendon sheath. It is underneath the tendon, okay? And the ligament is the band of tough tissue which restrain the joint movement. And tendon is a band of fibrous tissue by which muscle is attached to the bone. So we have the ligament here that stabilize the joint, and we have the tendon, as you can see here. This is the muscle, the tendon sheath, and underneath there is a bursa. The enthesis is the anatomical sites where there is attachment between the ligament and the joint capsule and the bone. It is here. See it? Do you see it, Yashaba?
Yes.
Yes.
So synovium, as we said earlier, it is very important structure. It is a thin membrane, is one cell line usually within the joint capsule. It produces synovial fluid. What is the function of synovial fluid?
Prevent the friction between the two cartilage.
Lubrication.
And what?
Lubrication, doctor.
Friction, lubrication, and also nourishes the nutrients to the joint, to the capsule, comes from the synovium. You know, the capsule, the cartilage is not involving blood vessels. So the fluid from the synovial fluid does give nourishment and nutrients to the cartilage. Basically, you already said about it. It is fluid-filled sac found between tissue planes, where shearing forces may act, like the knee and the elbows. They are lined by synovium, and they contain synovial fluid as well. So, what is rheumatism? So we knew about rheumatology, that it is the science that does deal with the musculoskeletal system and connective tissue disease and its disorders. So what is rheumatism itself? What is rheumatism يا شباب؟
pain يا دكتور مكتوبة قدام.
So it's medical conditions affect bones, joints, muscles, and tendons, causing pain. So arthritis itself is part of the rheumatism. It means inflammation of the joint. And arthritis does not mean does not contain the whole rheumatism. Arthritis is part of rheumatism, and there are other parts of rheumatism. Like in Italy, for example, you have bleuritis, you have arthritis, you have hematological diseases, and others. Rheumatic disease affects joints, tendons, ligaments, muscles, and can affect also internal organs, as we said, like in lupus. And there are multiple diseases and multiple syndromes. All of them, they are immune and inflammatory process. Okay?
Clear, yeah.
Okay?
Yes, yes.
You refer to collagen vascular diseases because
Yes.
they most frequently affected is by the immune and inflammatory process involve the collagen and connective tissue disease as well as blood vessels. Like in SLE vasculitis, you can see generalized internal body organs affected as well. In rheumatoid arthritis itself, which is a joint primarily affecting the joint, it has also extra-articular manifestations, including vasculitis, myocarditis, so it might affect also the internal organs. So in general terminology, in general, inflammation means reaction that leads to injury. It can come acute or chronic, like acute, like what happens in burns, or sometimes in gouty arthritis, and sometimes it comes as chronic process like what is there in rheumatoid arthritis. Arthropathy means joint disorder, can be arthralgia, which is just pain, or arthritis, which means inflammation and pain. So the arthritis, which is inflammation of the joints, can be monoarthritis, one joint inflamed only, like what happened in osteoarthritis generally, or what happens in gouty attack of gouty arthritis. Usually comes in gouty attacks in monoarthritis, and also can happen in septic arthritis as monoarthritis. Oligopolyarthritis, which is less than 4 joints, inflamed polyarthritis, which comes in more than 4 joints, or 4 or more. It can come as acute or as chronic attack as well. In general, inflammatory arthritis can lead to deformities, which is abnormal shape or size, and malalignment of articulating joints, and damage to the supporting structures, subluxation, which is malalignment of the joint, So the articulating surfaces incompletely approximate each other. Dislocation, displacement of the joint, and extra-articular features, as we said, that affect other systems other than the joint's area. So what is the difference between subluxation and deformity?
Deformity means change in the shape, and subluxation is just malposition.
Alignment. Okay?
Yes.
So the common symptoms in arthritis and rheumatic diseases like inflammatory arthritis in general includes joints pain, either the joint itself, articular, or the surrounding structures like capsules or ligaments like periarticular. It leads to joint stiffness. And in inflammatory process, we usually speak about morning stiffness. In general, wrist stiffness, which comes after a long period of rest. While in mechanical arthritis, the pain comes after movement. While here, this stiffness is evolving with movement. We have also joint swelling, joint deformity, movement limitation. So the patient is unable to move his joint, which leads to loss of function and sometimes to systemic illness and extra-articular manifestations. In general, if you received a patient in your clinic and he's complaining of musculoskeletal pain, what you will ask him about?
Family history.
One joint or more joints.
What else?
The
Family history
onset,
about the rheumatoid
This is
arthritis.
traumatic.
aggravating and relieving factor of the pain itself.
The time that the pain come early in the morning, late in the night, like this.
The severity of the pain and the onset, does it start gradually or acute?
Does any one of his family member has like this symptom or not?
Is there limitation in the movement or not?
Does there any painful or change in the range of motion?
Do you have
Is there
fever?
any redness combined with?
Is there any fuel?
So in general, you will need to start systemic history that will lead to the explanation of the symptom and will guide you to the diagnosis. It could be systemic. So as any pain, you have 10 questions to ask about, which is the onset of the pain, location, aggravating or relieving factor, and the
Timing.
accompanying features and the location of the pain, and if there is any affliction in other organs. So you have 10 questions, as we said, and the grade of the pain, and what is the aggravating or relieving factors, and the nature of the pain itself. But in joints, you have to focus on also, is this pain inflammatory or non-inflammatory? Why?
Because
الدكتور ما فهمت السؤال.
different treatment, doctor.
So in general, what is inflammatory pain and what is non-inflammatory pain?
non-inflammatory like osteoarthritis, wear and tear, and inflammatory like septic arthritis, which needs antibiotics.
I think inflammatory may come with fever.
To start with, rheumatoid does not need antibiotic. Okay? Inflammatory means,
All the time.
yeah, rheumatoid does not need. But it's an autoimmune process. It's not infection. Septic arthritis does need, but rheumatoid, no, doesn't need. Sometimes you have patient who's having systemic rheumatoid, but he has, for one reason or the other, he had septic arthritis in one joint. So yeah, you need to treat the infection. But rheumatoid itself is autoimmune disease. So inflammatory pain means it comes at rest, improves by activity. Okay? Associated with morning stiffness and awake patient from sleep. This is these characters are involving inflammatory process, which comes in rheumatoid arthritis and other rheumatological illnesses. While non-inflammatory is the mechanical pain, like an osteoarthritis, which comes with activity and improves if patient takes some rest. And the stiffness is brief, less than 5 minutes, 10 minutes. But while in rheumatoid, it's more than 30 minutes. Also, you need to ask about number of joints affected, because the pattern of the joints and the number does guide you in diagnosing the patient, which type of rheumatological illnesses is having. And the pattern of joint involvement, either this is migratory or additive. Additive means one joint is affected and the other is affected at the same time after that, but they are both having the pain. While migratory, like in rheumatic fever, it comes in one joint, then goes to other joints, and the first joint will be free of pain. Okay?
Doctor, inflammatory improves with activity.
Yes, usually. The stiffness is for more time, for more than 30 minutes, and improves with activity. While the other, the osteoarthritis non-inflammatory, increase with activity and improves with rest, and the stiffness is brief, only 5 minutes, 10 minutes, less than 30 minutes in general.
In the morning, stiffness.
This morning stiffness comes with rheumatoid.
Wow.
So we have different type of inflammatory arthritis. We have rheumatoid arthritis, which usually comes systemic in small joints of the hands, mainly BIBs and MCBs, both hands. We have some arthropathy, like ankylosing spondylitis, which affects the lumbar spine and the sacroiliac joints. It can come also peripherally in the hands joints. Psoriatic arthritis can also affect the back and can affect the sacroiliac joint and can affect the hands. Reactive arthritis, which comes with infection, and enteropathic arthritis, which comes with inflammatory bowel diseases. We have other systemic illnesses like SLE, and which is lupus and Sjogren's and scleroderma, which has also other manifestations like joints pain, but they have the systemic manifestation like muscle pain and bleuritis and skin inflammation and skin rashes. Polymyalgia, rheumatic vasculitis, and other infectious and undifferentiated connective tissue diseases. Polymyalgia rheumatica does affect the elderly and comes in the shoulders and hips stiffness. Vasculitis, there are different type of vasculitis, including, for example, Wegener disease, and including giant cell arthritis, and many other diseases. That mainly blood vessels are affected, either small, medium, or large blood vessels. The definition of inflammatory is here. There is more prolonged morning stiffness. Constitutional symptoms are there, like fever, weight loss. The involves with activity and symmetrical involvement is common. There are signs of effusion and inflammation and pain and loss of function, while you have the non-inflammatory like osteoarthritis, which is brief, only stiffness, and there's no systemic illnesses or constitutional symptoms, and it's associated with crepitus, but less inflammatory and swelling. We spoke about this, and so infections and infectious arthritis are main differential of other inflammatory arthritis, and they are different in management, and you should be able to treat the patient, because infection can be treated easily with antibiotic, but if left, it will lead to destruction and might lead systemic illness like sepsis and septic shock. While rheumatological illnesses like rheumatoid arthritis are autoimmune diseases which needs immunosuppression, not antibiotic, and they need long-term management. Okay, Shabab? In infectious arthritis, the germ invade the joint, and it might spread to the joint through bloodstream from the body, like what patient who is having dental procedure and is having infection, or if he's having IV line infection, then it goes to the blood and then go to the joint, or it can come directly after a trauma or surgery to the joint. There are types of infectious arthritis. Septic arthritis is acute, like it usually involves one joint, and TB arthritis, which comes chronic usually and less severe symptoms initially, but it has systemic symptoms like TB, and viral arthritis, like in hepatitis or EBV virus infection, which can come as systemic arthritis. As you may know, septic arthritis is a medical emergency. Acute destruction of joint might happen, and it might lead also to systemic illness. How to diagnose infectious arthritis, Shabab? معي شباب؟
دكتور.
Aspiration.
Aspiration and cultures. Aspiration, fluid analysis, cultures, blood cultures, and culture from the synovial fluid itself, and X-rays might help in doing that. Treatment with IV antibiotic and draining of the pus, and then after that you need to do rehabilitation of the joint. Viral arthritis, most of them are self-limiting. You need to treat the underlying illness if there is like hepatitis. One of them is parvovirus infection, which is the presentation in EBV and parvovirus infection. It looks like rheumatoid arthritis, but it is short term only.
Does not need any treatment?
For the treatment of the virus itself, but not for the joint pain itself. So you treat the underlying illness, the virus, if there is a complication of the virus, or there is hepatitis B or C or Billa or HIV, they will treat them as infectious process. But the arthritis itself doesn't need only painkiller and maybe intra-articular steroid if needed. This is slab C crash, part of the parvovirus infection in a child. So you see the systemic illness is there, and he has also joints disease.
This is doctor infection arthritis or what?
This is not infectious. This is not a septic arthritis. It's infectious arthritis because it's caused by infection, but doesn't mean that the virus is in the joint. No, it's systemic illness that affect the joint.
يعني دكتور صورة البنت اللي قبل شوي بارفو فيروس انفكشن صحيح؟
Yes, yes. In the US, they have systemic features. Reactive is reaction to the infection away from the joint, like what happens in the intestines, urinary tract, UTI. And the pathogen does not invade the joint capsule. And it can come from Salmonella, Shigella, Campylobacter, food poisoning. Also can happen with sexually transmitted diseases and chlamydia, gonorrhea, and HIV. It might affect several joints, usually short-lived, but if some patient might have long-term arthritis, it might last for less than 6 to 12 months, but some people, they have longer. Not common, but they have, some of them. Diagnosed based on systemic illness and the joints aspiration and the clinical manifestations. The treatment usually is non-steroidal, local injections, but if patients have resistant arthritis, then you might need to add immunosuppressive treatment. And most of them, they get better. الآن أتوقع أنك you need to do another link.
ما يحتاج دكتور، إذا وقف نرجع لنفس الرابط. يعيد من أول يعطينا 40 دقيقة.
Okay. So the signs. Now we'll speak about the signs and finding in rheumatological illnesses. They are variable. It might come in one disease and the other disease as well. Some of them are specific, but some of them are not specific. They help you in history and examination and differential diagnosis. For example, rheumatoid arthritis. What you see here?
Nodule, deviation to other side,
What else?
deformity.
Deformities. So you can see this is botanier deformity, and here you can see swan neck, which is more obvious here.
وش اسمها دكتور؟
This is botanier, and this is swan neck deformity. Swan neck deformity. Okay?
ring finger دكتور finger ring
Okay?
بونتين
botanier deformity.
موجودة تحت صح دكتور، هذه اسمها السبلينج.
ايوه ايوه.
إيه.
botanier. Okay?
يعني دكتور البوتانير والزد ديفورميتي نفس بعض؟
لا different.
كيف الزد ديفورمتي طيب؟
shape. Botanier flexion of the proximal and hyperextension of the distal. This is the distal and this is the proximal. You can see flexion here, extension. In BIB and the thumb Z deformity, what you can see here is only one BIB joint, no DIB joints here. The thumb. The Z is all usually in the thumb finger. واضح هنا شباب ولا لا؟
اي واضح، هذا الزد.
هذا الزد. On this one.
وهذه بونتينير.
And if there is extension of the proximal and flexion of the distal, this is axial botanier, which is swan neck deformity.
وين هذا سوان نيك؟
Here you can, this is the proximal BIB and this is the distal BIB. Okay? Proximal here is flexion and distal is extended. This is what we call botanier deformity. If the distal is flexed and the proximal is extended, this is what we call it swan neck. زي طيار البجا، زي عقبة البجا. Okay? Again, same. But here also you can see squaring of both hands and muscles atrophy.
الريوماتيك نوديولز هذه دكتور؟
Yes. You can see here early inflammatory process, intermediate, starting of the deformity to happen, and now late rheumatoid arthritis. As you can see here, the fixed deformity already happened, which is late stage of the disease. Nodules you already saw. Again, nodules. Nodules can come in the joints and in friction areas. You can see here the friction areas, the area which is exposed to the friction, like back of the neck and dorsum of the hands. Here you can see also extra-articular manifestation of rheumatoid arthritis, which is episcleritis. Now it goes to SLE. Rheumatoid is واضح ولا is clear or not?
واضح.
واضح.
So lupus, what you see here?
ارثميتوس زي كذا.
rash.
erythema on the face.
Butterfly face. في صوت ولا؟
Yes. نسمع صوتك.
So what you see here is erythema, yes, which is bearing the nasolabial fold. So it's affecting the cheek, but not nasolabial fold, which is called butterfly rash. Again, what you see here?
Same, Dr. Rash.
Same, butterfly rash.
Butterfly. It's bearing what?
The nasal fold.
Nasolabial fold, this area. What is this?
Extension of the BIB and deflection of the
So is
the last one.
deformity of the joint. So is arthritis in the lupus, right? But what is the difference between arthritis in the joints in lupus and in rheumatoid?
No deformity.
The
No
lupus
squaring.
arthritis deformity is reducible. It comes back to normal.
الاس دي
It becomes reducible, which is mean laxity of the joint. But in rheumatoid is not reducible. It's not lax. It's fixed deformity. واضح شباب؟
في الروماتويد فيكست يعني ما هنا ترجع مع التريتمنت.
reducible يدك ترجعها.
هذا قصدك دكتور؟
Yeah, means laxity. It's not deforming usually like. This is what we call Jacquard arthropathy, which means lax joint. Lax. لينة ها؟ You can reduce it. مخاوة أيوه. What is this?
Cyanosis.
Reynolds phenomenon.
Rhinoid phenomenon, which is
vasoconstriction.
Abnormal peripheral vasoconstriction
okay
in the arteries.
Okay, it's vasoconstriction followed by vasodilation caused by exposure to the either emotional stress or to the cold. It can come as primary and it can come as secondary to other systemic disease like lupus or scleroderma. Usually the joints comes white, the skin goes to white color, mean no blood, then cyanosed, blue color, and then hypererythema happens and it turns to it. This is the usual way, pathway. But sometimes it does not come typical like that. You can see here, the bale joint, the bale skin, and then it's cyanosed, and then hypererythema it.
ليش دكتور لونها اصفر طيب يعني؟ المفروض يكون
لانه بيل، هذا بيل زي يسموه زي capillary fill. Bale no blood, blue cyanosed, and red blood.
معلش دكتور ما فهمت النقطة هذه كان صوتي قطع.
When there is no blood supply, like capillary fill, it will turns to white or blue, like this. Not blue, yellow. No blood supply, based on the skin, yeah. And then it happens to turn into blue. There is no blood flow, and there is cyanosis. And then hypererythema happens because the blood flow turns back and turns into flashy red color. This is the rhinoid phenomenon.
يعني أبيض يا دكتور أول شيء بعدين
أبيض
بعدين
أزرق أحمر. White, blue, red. هذا typical, لكن maybe not comes like typical. But in general, it is vasoconstriction followed by vasodilation. Sometimes it causes severe vasoconstriction, which leads to necrosis and ulcers. Okay? واضح يا شباب؟
واضح دكتور.
يعني دكتور, this is a symptom, not a disease.
It can come as primary idiopathic rhinoid phenomena, or it can come as secondary to either lupus or systemic sclerosis or to other illnesses. Okay?
Okay.
Other skin manifestation, what we call discoid lupus, raised red papules of legs, central thinning and follicular plugging, heals with scar. It can come in the scalp, face, or neck, or ear, or behind the ear. It can come with systemic lupus, and it can come as only discoid lupus in the skin only. So it can come as lupus with systemic manifestation, or it can come as only skin manifestation. And lupus can come complete or incomplete. واضح يا شباب؟
هذه الثعلبة دكتور ولا؟
ها؟
هذه الثعلبة يسمونها ولا تختلف؟
لا ما هي الثعلبة، هذه الذيبة اللي عم نتكلم عنها. Discoid lupus. الثعلبة means no blood, no hair.
Alopecia.
Alopecia, yeah. What is here? What do you see here?
ulcer,
Mouth ulcer.
Ulcer.
Then lupus. What is here?
rash,
Rash, subcutaneous acute, subacute cutaneous lupus. This is again discoid, lupus. So we have discoid lupus, we have malaerythema, and we have subacute lupus. What is this?
fasciculitis ممكن دكتور.
Part of it. So it's skin manifestation of lupus, ulcers, lupus bufundus, and this is what we call livido reticularis. It can come with lupus and with antiphospholipid syndrome. تعرفوا الانتيفوسفوليبيد؟
لا وش ذا؟
So hypercoagulability state. Patient is born to thrombosis, DVTs, and also born to abortion of the babies. Okay? This is what we call livido reticularis. Here is a patient with lupus, presented with shortness of breath and hemoptysis, and found to have pulmonary hemorrhage. So, lupus can affect blood vessels, including blood vessels of the lung, and can cause pulmonary hemorrhage, which is medical emergency. This is a pulmonary hemorrhage, what you can see here. Systemic sclerosis. واضحة اللوبس شباب؟
كلها دكتور ديسكويد والاشياء الثانيه كلها كلينيكال مانيفستيشن.
كلها كلينيكال مانيفستيشن.
يعني هي تبع السيستميك لوبس صحيح دكتور؟
ايوه بس الديسكويد it can come without systemic disease lupus. So it can come localized lupus.
تمام.
So systemic sclerosis. What is systemic sclerosis?
هذا نص يدك بيض ونص يدك حمراء.
هذاك رينولدز.
Raynaud phenomenon.
Can come with Raynaud phenomena. Yeah, so this is Raynaud phenomena. But ايش هو systemic sclerosis? هو tightening of the skin. You can see either localized tightening, like here, and shiny skin, very tight skin, and it can cause systemic. There is very severe tight skin, تصلب الجلد يسموه. But it's associated with systemic manifestations like renal disease and interstitial lung disease. It can cause ulcers, it can cause watermelon gave phenomena in the stomach, vasodilation of blood vessels in the stomach and causing anemia and hemorrhage. And this is the picture of the patient with systemic sclerosis. You see tight skin around the mouth, beak, nose. The gingiva is retracted away from the dental roots, and bilateral skin tightening, and telangiectasia in the face as well, and in the mouth. Very tight skin causing ulcer. You see, this is normal skin. This is very tight skin. It's very bad and severe disease, very bad disease. It is either localized or systemic, and it can cause interstitial lung disease, and eventually it might lead to death, and it might cause renal crisis. Okay, Shabab? This is digital ulcer with scleroderma. وترتاح شوي ولا كمل؟
لا تفضل دكتور.
كمل دكتور.
كم عندنا اختبار.
متى اختباركم؟
بكره بس عشان نذاكر باقي لنا شيء.
اوكي.
عشان ودنا نخلص يعني اسرع ما يمدي.
طيب dermatomyositis and polymyositis. What do you see here? What do you know about dermatomyositis?
والله دكتور أول مرة أسمع عنها.
ما في أحد سمع عنها؟
والله.
Myositis means inflammation of the muscles, صح? It can come with skin manifestations, and it can come without skin manifestations. If it comes with skin, dermatomyositis. If it comes without skin, it causes polymyositis. There are different parts of different types, and don't need to know about now, but dermatomyositis and polymyositis usually affect proximal muscles, and it might cause lung symptoms. And it might be associated, dermatomyositis might be associated with cancers. Here, what we call Gutton babules, you see the erythema and the skin rash around on the joint itself, on the knuckles also. You see, not in between, on the joints and around the nails. And this is what we call mechanic hand, seen with one type of polymyositis called antisynthetase syndrome. You can see the fissuring of the hands, of the nails, of the fingers. This is a well-known sign seen in dermatomyositis called Schawel sign. Also around the eye, what we call heliotrope eruption or heliotropic rash, seen in dermatomyositis. And this is nail fold changes, seen also in dermatomyositis. The angular erythema, also around the thigh, what we call Ulster sign. This is patient juvenile, which is young age, who is having systemic dermatomyositis. You can see the rash here, and Gutton's babules, and heliotropic rash. Okay, شباب?
يعني دكتور درماتو مايوسايتس هذا يجي في المصل وفي السكن.
Yes.
اما بولي مايوسايتس هذا بس يعني في المصل.
Yeah.
وفي اللنج.
All can affect lungs, huh? Both. So vasculitis, what do you know about vasculitis? معي شباب؟
معك دكتور.
Yes.
ايش هي الفاسكولايتس؟
Inflammation of the blood vessel يعني.
So blood vessels there are many types of blood vessels.
Middle.
Blood vessels, medium blood vessels, and large blood vessels. So we have diseases affecting all blood vessels and different types of them. This is what one of them, which is called Wegener granulomatosis, or our other name is granulomatosis with polyangiitis, causing systemic disease in patients who are presenting with recurrent sinusitis, nasal septal deformity, as you can see here, and it does affect small blood vessels. It can cause also pulmonary hemorrhage. And this is another disease called Bahjat disease. Do you know about it?
Yes, come in the eye.
Mouth ulcers, genital ulcers, and other diseases like eye inflammation, retinitis, joint diseases, and others, and skin manifestations. Okay? This is what we call giant cell arteritis or temporal arteritis. You can see here the temporal artery is inflamed. It affects large vessels. It might lead to blindness or critical illness in the body. Okay? So we need to treat this as rheumatological emergency. You should give him steroid initially to save his eye. Other disease called henoxylline berber, which comes after respiratory respiratory infection. It is IgA, it affects small vessel disease involved by IgA complex deposition. It can come to the scrotal swelling, abdominal pain, intussusception, arthritis, arthralgia, renal involvement, and hematuria or hematochezia. This is the picture of henoxylline berber, skin rash and the lower limb, followed. It comes after the respiratory tract infection. واضحة هذه شباب؟ واضحة؟ So عندنا قلنا large vessel disease, small vessel diseases, and we have reactive diseases in small vessels like henoxylline berber.
Wegener small vessel صح ده؟
Yes, Wegener small vessels, and the others like microscopic polyangiitis, and Church-Strauss disease, all are small vessels disease.
والبهجة small vessels.
Small vessel, yeah. Bahjat can affect different types of vessels. It can affect large, mainly large, but it can affect different types of vessels. It might cause pulmonary hemorrhage, it might cause aortic aneurysm, it might affect large vessels, it might cause strokes in the brain as well, and it might cause small vessel disease. So it is general vasculitis.
All vessels affected.
Yes. But what is unique about Bahjat is the ulcer and genital ulcer, mouth and genital ulcers. Besides that, it might leads to hemorrhage and aneurysm in the large blood vessels. Okay, pulmonary artery or aortic artery. Okay. Do you know anything about crystal-induced arthritis?
Maybe like gouty arthritis. I think.
Gout and pseudo gout. Huh? What is this?
Gout.
What is this?
Crystals.
Deposition, what we call it tophi. Can come in the joints, but also can come in the ear, as you can see here. What
هذا
is this?
سبب اليوريك اسيد دكتور زايد يعني في الجسم.
ألا؟
سببها زيادة اليوريك اسيد يعني.
أيوه، either under secretion or over production. What is this?
Crystal.
So needle-shaped crystals, negative birefringent on the light microscope. This is what's seen in the gout. While pseudo gout, you can see rhomboid shape or positive birefringent, calcium biophosphate position. Okay? So in gout, uric acid, which is negative birefringent, while in pseudo gout or crystal or calcium biophosphate crystals is positive. Okay?
وش هذه تقول؟
الكريستالز التايب اوف كريستالز في الجاوت والسودو جاوت. جاوت is uric crystal, uric acid صح ولا لا؟
يس بالضبط.
السودو جاوت is calcium deposition. calcium biphosphate. في اللايت ميكروسكوب الجاوت اليوريك اسيد is negative, يسموها negative birefringent. في اللايت ميكروسكوب تحت الميكروسكوب. While it is positive, weakly positive here in calcium.
كالسيوم سودو جاوت، يوريك اسيد جاوت.
This gout,
صح؟
yes.
واللي تقول لي بوزيتيف هذا يا دكتور رامبر.
في اللايت ميكروسكوب. Under light microscope. Under polarized light microscope. They gum positive, gum negative. Psoriatic arthritis, what is this? What is this?
سكن سوراريس، ما ادري كيف تنطق.
Psoriasis.
Right, the psoriatic patch, yeah? It can be either diffuse or limited psoriatic patches. And though because it is autoimmune disease, it can affect the joints. What you see here?
Thickened.
Swelling.
The joint is inflamed, swollen. This is what we call dactylitis. Sausage-like joint, the whole joint, proximal and distal, and the whole joint subcutaneous tissue is inflamed.
وش الديزيز هذا يا دكتور اسمه؟
Psoriatic arthritis. يعني التهاب المفاصل الصدفي. يجي مع اللي هي السورايسيس. هذه what we call dactylitis أو sausage digit.
زي السوسج.
ايوه زي السوسج. And it can cause very severe deformity and very aggressive what we call arthritis mutilans. Okay? Reactive arthritis. What is reactive arthritis يا شباب؟ تكلمنا عنه.
arthritis تفاقم.
تجي من الانفكشن systemic.
not respond to treatment.
في صوت شباب؟
ما في
في
صوت.
الآن أسمعكم.
الدكتور صوته طالع ولا؟
لا ما
لا،
أسمع.
موجود.
Reactive arthritis يا شباب it comes after either infection or after systemic illness like inflammatory bowel disease. Here, what we call Reiter syndrome. It comes with triad of conjunctivitis, genital infection, and arthritis. You can see here these venous ulcers, or what we call circinate balanitis, and it associated with keratoderma bilineogicum. This is keratoderma bilineogicum. You can see CV keratoderma bilineogicum.
كأنها بهجة يا دكتور، فيها conjunctivitis. إيش بعد؟
انت قصدك بهجة لانه هم بس هذه انفكشن.
الدكتور يجمعها كونجكتيفايتس و infection.
Bahjat comes with oral ulcers and genital ulcers, not infectious genital ulcers, autoimmune ulcers, and it can affect the eyes. Here, the Reiter syndrome is a genital infection, conjunctivitis, and then arthritis.
زي السيفلس دكتور تايب 3.
زي syphilis. It might come as sexually transmitted disease. Okay, what you see here, Shabab?
Deformity of the proximal distal joint.
Okay, this is what? Deformity and nodules, huh? But it might be is not واضح, is not clear here. So distal nodules called Heberden nodules, which comes in osteoarthritis. Also, if it comes at proximal, distal means distal IB, distal interpharyngeal joint, and proximal interpharyngeal joint. If you have deformity and nodules in the distal, it is called Heberden nodules. If it is in proximal, it's called Bouchard nodules. Okay?
هذه اللي أخذناها أول دكتور صح؟
Yes, yes. بس ما هي rheumatoid, هذه is osteoarthritis. So the last lecture is about laboratory investigations in rheumatological diseases. So as we said initially, you should evaluate the patient, take fluid history, and you do examination, you look for the signs. If he's having inflammatory process like rheumatoid or septic or crystal induced, or if non-inflammatory, if he's having osteoarthritis or trauma, or if he having non-articular inflammation like bursitis or tendinitis or polymyalgia or meticulous inflammation of the joint tendon. And then after that, the GP should know about rheumatological illnesses and their presentation, because if left untreated, it might lead to permanent long-term outcomes. For example, if a patient comes to you with knee swelling, tenderness, pain, and fever, then you need to do synovial fluid analysis. Why?
Septic joint ممكن دكتور.
Rule out septic joint. When the other differential of septic joint is gouty arthritis, because it comes also monoarthritis and causes inflammation. صح يا شباب؟
صحيح.
صحيح. So you analyze the fluid, you look for the WBC. If it is less than 1,000, it is what white blood cell in the synovial fluid. This is non-inflammatory. It might be osteoarthritis. If it is between 5,000 to 20,000 WBCs in the synovial fluid, this might be inflammatory, but it might not be infection. It might be rheumatoid. It might be crystal induced. But if it is more than 50,000, then it most likely it is septic. So how do you know? For the crystals, you do crystals. زي ما قلنا undoubleized light. You see the negative needle-shaped crystals. For infection, you need to do septic culture, and you need to do cultures from the synovial fluid, and you need to do gum stains. صح يا شباب؟
صحيح.
Other labs you can do is systemic labs, which does contain antinuclear antibodies, C-reactive protein and ESR, rheumatoid factor, anti-cytolynated peptide antibody, and also uric acid in the blood. And other labs including ANCA, which anti-neutrophil cytoplasmic antibodies. This is one, the first one, which is called ANCA, is seen in Wegener granulomatosis. ANA is seen in lupus. C-reactive protein and ESR means that there is inflammation and inflammatory process. It becomes high in active inflammation in general, is not specific. Rheumatoid factor and CCB usually comes positive in rheumatoid, but rheumatoid factor is not specific, while anti-CCB is specific for rheumatoid. And uric acid, you can do it to know if the patient is exposed to hyperuricemia, which might lead to what?
To gout.
Yes. Gout does mean hyperuricemia plus inflammation of the joint. While hyperuricemia itself does not mean gout, but it predisposes patient to get gout.
لازم في deposition.
ها؟
لازم في deposition of uric acid.
ايوه لكن اذا ما في deposition then it is not gout, huh?
Exactly.
في صوت؟
ايه في صوت اسمعك.
ايه في
معلش يا شباب المهم so in general
دكتور ممكن تلخص لنا اللابز بسرعة؟ تقل ما أحس إني فهمتها زين.
وش؟
اللاب انفستيجيشن الجدول اللي قبل شوي.
So we have different labs in rheumatology, including ANA, which is seen positive in rheumatoid and lupus. And the other one is C-reactive protein and ESR, which is active in any inflammation, not only in rheumatological illnesses. We have rheumatoid factor and CCB, which we are using in rheumatoid arthritis. And you have uric acid, which you use for gout. Anti-neutrophil cytoplasmic antibodies, اللي هي ANCA, they are two types, C-ANCA and B-ANCA. C-ANCA seen in Wegener, B-ANCA seen in other diseases called microscopic polyangiitis and Shake-Strauss syndrome. We'll come to every one of them. So, rheumatoid is symmetrical inflammatory pain in more small joints associated with morning stiffness more than 1 hour. CBC finding are variable, but you might see neutropenia, splenomegaly, in what we call Felty syndrome, and high ESR CRP, and you need to follow other labs like renal function, liver function, and the rheumatoid factor is positive in 70% of patients. And CCB is positive and very specific anti-CCB positive antibodies. Like if patient comes to you with negative rheumatoid factor and negative anti-CCB, you have the chance of 20 to 30% to have rheumatoid, and that's what we call is CO negative. So if we have rheumatoid and CCB, this is what we call CO positive. If we don't have it and patient is having rheumatoid, then this is CO negative arthritis. واضح يا شباب؟
واضح يا دكتور.
قلنا rheumatoid factor non-specific while CCB is highly specific. You can do imaging, ultrasound, brain X-rays, and MRI, and also ultrasound can give you the activity of the disease. If it is active, this Doppler sign will become positive. X-ray will show you the erosions, and it will show you the periarticular osteopenia. So if you did the X-ray of the joint, you can see periarticular swelling, periarticular osteopenia, marginal erosion of the joint, narrowing of the joint space, subluxation of the gross deformity, and ankylosis. You can see here clearly that there's periarticular osteopenia. This black discoloration here means osteopenia. Periarticular, you can see here clearly the joint space is not intact, and you might see mild erosion here, periarticular. واضح شباب؟
And small space between the joint.
Small space, what we call also periarticular osteopenia, يعني osteopenia, which means fragility of the bone itself is not intact. You can see it here, osteopenia, osteoporosis, هشاشة.
واضح.
Okay, and also destruction of the joint, as you can see here.
في deformity.
Erosions here, periarticular. Okay, and rheumatoid does not invade distal, only proximal.
Only
proximal, not distal. Here, clear, you can see the erosion. You can see osteopenia, periarticular osteopenia around the joint, swelling of the soft tissue as well. And here, you can see clear the deformity of the joint. صح يا شباب؟
نعم صح. Deformity.
Deformities. This is ultrasound showing you the activity, the inflammatory activity around the joint space, and synovial fluid is inflamed. Also, MRI can show the same. X-ray. This is the osteoarthritis because it involves the distal. This is rheumatoid arthritis.
Rheumatoid proximal.
Yeah, but distal is osteoarthritis.
Clear.
This is the main differences between gouty, osteoarthritis, and rheumatoid. Gout attacks comes at sudden and goes away by itself. Initially, it comes attacking one joint, lasts for a few days, and then goes away. And then after some time, another attacks come. After some time, after long term, it causes lesions and causes deformities. Okay? Lupus. قلنا الانتي سكرين anti-nuclear and anti-nuclear antibodies is a screening test, non-specific, but is needed to diagnose lupus. Anti-double strand seen only in 30% of the cases, but it is very specific. Other antibodies, anti-SSA, anti-SSB. You also need to do CBC because patients with lupus, they have leukopenia, they have lymphopenia, they have thrombocytopenia, they have anemia, and they have CRP high. CRP not high usually, but if he's having cystitis or infection, it might become high. ESR is high, and you need to do urine analysis because patients with lupus, they might have kidneys affected, which cause hematuria, proteinuria, and cast, and this time what we call it lupus nephritis. If you suspect lupus nephritis, you need to do what?
Kidney function test.
And?
CBC.
No.
Microscope دكتور نشوف urine analysis.
You need to do biopsy of the renal. 50% sensitivity. Okay?
يعني الدكتور النسبة هي نسبة السنسيتيفيتي لكن ما هي specificity.
No. Yes. You can see here specific coacily and double strand. Specific coacily and Smith. But sensitivity is only 25% and 70%. Okay? What you see here?
Hemorrhage.
It's not hemorrhage. You can see, you don't know it's hemorrhage or not. You
It's
see, yeah, it's wetting, but you don't know in X-ray. You can see the white patch, it is opacities and diffuse opacities in the lung. And patient is intubated. So he's having hypoxia. They did for him this. What is this?
This is aspiration, doctor.
This is what we call bronchoalveolar lavage. And they saw the blood there. And they did the septic workup, it came negative, he's having pulmonary hemorrhage secondary to lupus. Also can come secondary to Wegener and other diseases. Okay, Shabab? Antiphospholipid antibody, as قلنا is recurrent abortions, unexplained deep vein thrombosis or pulmonary embolism. You will do the labs for the patient and you'll see that the patient is having positive lupus anticoagulant or anticardiolipine or anti-beta 2 glycoprotein or all of them. You will see also prolonged BTT or BT. That is not corrected by adding normal plasma because there's antibody there. Sjogren syndrome. Do you know about Sjogren syndrome?
No.
Sjogren disease means sicca or keratoconjunctivitis sicca in the eyes and mouth. So dryness of the eye and mouth and may be associated with salivary gland and parotid gland swelling. It can also come with systemic disease. It can come as primary Sjogren with extra glandular manifestation like neuropathy, arthropathy, and it can come as primary and it can come as secondary to other diseases. So you might have a patient who's having GSLD and he's having Sjogren's, or rheumatoid and he's having Sjogren's. So it can come secondary or primary, as we spoke in rheumatoid, in rhinoid phenomena. So it causes elevated ISR, hypergammaglobulinemia, autoantibodies positive, ANA and SSA, or what we call anti-O. Schema test, which is checkup being established to see if the patient is having low tears, and so it is not producing enough tears to lubricate the eye, or then it does not produce enough saliva to lubricate the mouth. They do lymph biopsy and they found focal lymphocytic infiltration of the salivary glands. Schema test, measure of the flow of tears over 5 minutes using paper strips based on the lower lacrimal sac. Or lip biopsy. This is the lip biopsy. Low to antibodies, this in systemic sclerosis. You remember the systemic sclerosis, huh?
Yes, yes.
What is it?
Tightening of the skin.
Okay, it can come as localized or diffuse. Anti-sickle 70 antibodies is seen in diffuse disease, anticentromere seen in localized disease. And this disease, these are parts of ANA. So there are subtypes of ANA. You see antisickle and anticentromere. And based on this, you look at and beside the clinical picture, you decide if the patient is having diffuse or localized systemic sclerosis.
دكتور الحين رجعنا للسيستميك سكلروسيس ولا كيف؟
ايوه لاب انفستيجيشن للسيستميك سكلروسيس. الحين نتكلم عن لاب انفستيجيشن في كل الروماتولوجيكال diseases. And this is what you see in capillary scope. Under the nail folds, you see dilated blood vessels and systemic sclerosis. adhesive to antum اللي هي البشرة أو tightening of the skin, and also it can come with calcinosis. You can see it here. Okay? تذكر البكشة هذه dilatation of blood vessels in the stomach, what we call watermelon picture.
هذه بس ديليشن.
Dilatation of blood vessels leads to anemia, hemorrhage, and others. Also dilatation and in the large intestine and small intestines as complications of systemic sclerosis. It is causing also pseudo obstruction. This is Bayam enema, you see it. And interstitial lung disease, as you can see here, in scleroderma as well. And polymyositis and dermatomyositis. What it is, as we said, inflammation of the muscles. So what do you investigate? How do you investigate this?
muscle enzyme.
Muscle enzyme like creatine kinase, or electromyography, EMG, electrophysiological study of the muscles, or you do muscle biopsy plus MRI to see the inflammation of the muscle.
What about AST, doctor?
Again?
AST, what about it? ينفع
A?
لما-
AST,
Yes.
this is liver function test. It's increasing also in myositis, but it's not specific. Okay?
Okay.
Some people, they have normal CK, but they have dermatomyositis because this is another enzyme like aldolase to be raised, to be high. And there are also antibodies seen in these patients, like anti-ANA can be seen also positive, anti-Jo and anti-MI2 and anti-SRB. اسمعوني شباب؟
ما اسمعش.
نعم.
والله كلهم فيهن انتي اي دكتور.
بعض الأحيان specific وبعض الأحيان لا.
أنا specific.
والله تلخبط كل
والله واللي
هذه الانتي جو والانتي ام اي 2 والانتي اس ار بي هذه كلها سب تايبس syndromic pictures of dermatomyositis and polymyositis. Subtype syndromes. Okay, anti-Jo seen with lung involvement, anti-MI2 in dermatomyositis, anti-SRB comes with cardiac involvement and does not respond to urinated treatment. Also muscle biopsy, they have specific features, and in MRI you see the TITSEC and the high signals. You might use brain swallow to see the swaying mobility. You need to do just screening for interstitial lung disease, like doing just X-ray and high resolution CTs. In gout, goodness, so we synovial, the definitive, this is gout now. The definite laboratory test to confirm gout is to see the crystals in the synovial fluid. This is the absolute, the definite investigation. If you could not see it, you might still consider gout, but you might be on as well. Okay? Osteoporosis. What does it mean, osteoporosis? It means the bones lacks its strength.
decrease in bone density.
So how to measure that? Initially, you can do X-ray. If you suspect
DEXA scan.
you do DEXA scan, or what we call bone marrow densitometry. Okay? You need also to do other enzymes, other labs, including serum calcium phosphate, and renal function, liver function, thyroid function tests, vitamin D, and BTH, and in patients who are males, you need to do 6 hormones, and amenorrheic patients also, women, you need to do 6 hormones. Some people, they do biopsy, but this is not really needed. I never did a biopsy for that. But if you have both types. So X-ray may not detect the osteoporosis early. It needs to lose, you need to lose 30% of the patient's bone until you can see it in the X-ray. So bone scan is the best one. Bone symmetry. Okay. So if you did bone symmetry and you found the score is less than minus 2.5, this is osteoporosis. If it is between -1 to minus 2.5, this is osteopenia. Still not osteoporosis, but not normal bone. Above -1 is normal bone. واضحة هذه شباب؟
واضحة.
واضحة. Okay. Other systemic vasculitis, like this is Takayasu arthritis. We spoke already about GCA, or giant cell arthritis, which is affecting
temporal artery.
Takayasu is affecting also large vessel. Some people they says it is a spectrum of GCA, but it affects younger people and it affects mainly subclavian arteries.
During the chewing, okay.
Chewing comes with both, but it causes coaction of the aorta and subclavian brachiocephalic artery, major artery to the limb. You can hear very different in blood pressure both sides. In investigation, you do MRA, angiography, CT angiography. You see the aneurysm and dilatation and occlusion. Labs non-specific, but you will have high ESR and anemia as well. سيانكا وبيانكا هذه اللي كنا نشوفها في الوجنا and in other وجنا سيانكا and ban أو polyarthritis nodosa and microscopic polyangiitis seen in P-ANCA. C-ANCA is more specific for vagina and seen in about more than 80% of the vagina, but P-ANCA is seen only in 40% of patients who are having microscopic polyangiitis. So we might have microscopic polyangiitis and vasculitis, while P-ANCA is negative. Okay شباب؟
معاك يا دكتور تفضل.
هذا صعب عليكم شوي.
اي والله صعب.
يا دكتور باقي على الفاينل اسبوع
هذا الانكا seen in Wigner, C anka mainly. B anka less specific but seen in other than Wigner. اوكي؟ ليه هذه؟ تعرف ويجنر اي واحد ويجنر صح؟ هذا ويجنر sinusitis and deformity in the nose in the nose. So the nose deformity. اوكي شباب؟
سي انكا.
هذه فيها سي انكا. في انكا في الاذرز لايك microscopic. وكلهم small vessel disease. اوكي شباب؟ الان hand examination. Just shortly and briefly, you need to know about hand examination. Usually in rheumatological examination, you do look, feel, and move. Okay, شباب? You look for the gait, swelling, deformity, redness, scars, swelling, and skin changes, wasting of the muscles, and contractions and deformities. You feel for joint tenderness, fullness, hotness, and warmth, and the margin of the joint capsule, and you ask the patient to move what we call active movement, or you do passive movement, or you do assisted movement to elicit the pain, and then you do special tests. You do inspect the hand for any scars, swelling, deformities, nail changes, and muscle wasting. The nail changes are very important. Okay? You do both from dorsal and the palms inspection, both sides. Okay?
Okay.
You can see here the deformities that we see the Z deformity, swelling deformity, and subluxation of the MCBs. You see the subluxation?
Yes.
You can see also the ulnar deviation. It's what we call ulnar deviation. And then it's used here as well. And then you do palpation, and you don't forget, after you finish the look, feel, and move, don't forget to do neurological examination and you do vascular examination as well. So during the examination, assess stiffness, tenderness, pain at motion, swelling, deformity, limitation of the movement, extra-articular manifestations, and the nodules.
كلها مركز على
And
الهاند
this is
صح
your
دكتور؟
guideline. Again, أيوة ركز على الهاند. Initially, you introduce yourself to the patient. You wash your hands. You wear gloves. Put the hands bonated on the pillow in front of you. Both look for the nails, fingers, dorsum. Ask him to bonate. Inspect the palm. Palpate for temperature, pulses, muscles, emissions in hypothena and thena, tendons. And also assist the bones and carpal bone metatarsals and the joints in RCBs, in BIBs and MCBs and DIBs, both sides. Ask him to flex, extend, and they abduct and adduct the joint, and raise the thumb also. Assist the power, the grip of the patient, and assist his, what you call the usual daily activities, to hold the pen, to close his t-shirt, and assist capillary refill, the sensation in both median nerve, radial nerve, and ulnar nerve, and do special tests. Phalanx and Tellens test. هذه seen in what?
في واحدة الكربل ترانسنتر.
كلها ثنتين. Phalanx and Tellens for what?
carpal tunnel.
carpal tunnel.
median nerve.
Tingling sensation.
Median nerve. So it's carpal tunnel syndrome. Finkelstein test. هذه seen في what we call the cavian tenosynovitis. هذه you don't need to talk about it. And then you don't forget to to cover the patient and to thank the patient, okay? And then clean your hand. Okay, شباب؟
Yes, gracias.
اوكي.
عندكم أي سؤال شباب؟
يعني دكتور ان شاء الله كذا نكون خلصنا جزئية الريماتولوجي كاملة.
لا باقي second part.
متى
ان شاء الله انه قصير يعني دكتور.
إن شاء الله مع الدكتور عبد العزيز هيكون second part. إن شاء الله include autoimmune diseases including the case discussions.
دكتور احنا اختبرنا يوم الاسبوع القادم يعني حتى ما قالوا لنا متى.
عشان كذا يوم الثلاثاء الدكتور عبد العزيز بيتكلم يتواصل معاكم وإن شاء الله يعطيكم محاضرات بريف إن شاء الله. الآن الجزء الأكبر خلصنا، باقي البريف إن شاء الله هتكون مع الدكتور عبد العزيز يوم الثلاثاء أو بكرة والله ما متأكد.
لأنه والله الدكتور منضغطين شوي حنا وتخبر يعني ما حددوا الاختبار متى.
إن شاء الله ما مو طيبة لا تخافوا. بس خلي عبد الله الجو بريدر يتواصل مع الدكتور عبد العزيز وبعطيه خبر إن شاء الله يعطيكم شيء بريف مو شيء يعني. تمام؟
يعطيك العافية دكتور.
الله يعافيك إن شاء الله. حياكم الله.